Thank you, sir. A very good afternoon to the respected chairpersons and August gathering. So the topic abstract, what I have been allotted is a ROBOCOP II study, randomized, that is randomized controlled feasibility trial of robot assisted versus conventional open partial nephrectomy. So this is a to start with, it should be clear that it's a feasibility trial. So, as we all know that partial nephrectomy is nowadays a standard of care for localized renal cell carcinomas or neoplasms whenever and wherever it is feasible by any means, by open or laparoscopic or robot-assisted laparoscopic method. But unfortunately, there is no level 1 evidence from any RCTs which can compare the robot-assisted partial nephrectomy to the open partial nephrectomy. So this is a major drawback when we don't have a level 1 evidence. So because as we all know that only randomization ensures the equal distribution of unknown confounders as compared to the any statistical methods like propensity score matching, which can adjust only known confounding factors. And to go ahead, surgical RCTs, they face unique challenges, which starts right from the standardization of the technique, learning curves of the surgeons, to the recruitment, which the recruitment of the patients, that means the accrual, is the most important reason for early trial discontinuation. It has been shown in many trials that around 50% of the surgical trials or the RCTs, they fail to reach their accrual target. That is the main reason of early termination of the studies. So this ROBOCOP II study was planned to assess the feasibility of trial recruitment primarily, and to compare the surgical outcomes between the robot-assisted partial nephrectomy and open partial nephrectomy. It was a single center open label feasibility trial with the patients randomized at 1:1 ratio to either robot assisted or open partial nephrectomy. So inclusion criteria were patients having 18 years of age who are capable of giving consents, and they were scheduled for a partial nephrectomy either by any of the method, by robotic or open method, with the intent to cure the patient. And patients who were able to understand the goal and the consequence of the study, and they were also understanding the alternatives to participation in the trial, means they can refuse or they can accept to undergo the trial, along with the good abdominal magnetic MR or the computed CT scan is available. So patient with a solitary kidney or patient with cognitive impairments like dementia who are otherwise not legally competent, patient having simultaneous second surgery, or patient having any emergency intervention right being explored for bleeding, multiple kidney tumors, or the second malignancy that would make the partial nephrectomy needless, they were excluded from this study. Primary outcome which were to be assessed was the feasibility of the trial recruitment, and that was actually assessed by the accrual rate, that and the target for that accrual was set to at least 33%. What is accrual rate? It is basically the number of patients who are fulfilling the eligible criteria and agreeing to participate in the proposed trial. These numbers are divided by the total number of all eligible patients within the recruitment time. So this is the accrual rate. So apart from the primary outcome, other secondary outcomes, they were also assessed. Those were operative time, conversion rate from robot assisted to open partial nephrectomy, or conversion from partial to radical nephrectomy, intra blood loss and need for any blood transfusion, warm ischemia time, trifecta, which was defined as no major complication, R0 resection, and warm ischemia time of 25 minutes. And the need of analgesia and post-operative complications and post-op kidney functions were also assessed as the secondary outcome measures. So this is a flowchart which shows that around 218 patients from June 2020 to November 21 were enrolled, and 140 patients were excluded based on the various factors like not suitable for the surgeries, having solitary kidney, bifocal tumor, multiple tumors, or patients having Bosniak cyst or metastatic tumors. After that, only 78 patients were found to be eligible to get accrued for this study. Patients were randomized in 1:1 ratio. So total 26 patients in each arm were found to be eligible. Out in robot-assisted partial nephrectomy, one patient refused to undergo surgery, and in open group, one patient undergo total nephrectomy because of the complication. Finally, in each group, 25 patients were analyzed for their primary and secondary outcomes, and they were followed up to 90 days. So as it was a feasibility trial, no formal sample size was calculated, but with respect to the primary endpoint, approximately 35% of eligible patients were targeted, fulfilling the exclusion criteria, who would agree to participate in the proposed trial. And that's why the sample size of at least 25 was calculated. So this is a table showing the baseline characteristics, which we can see there. These are comparable in both the groups. So as we come to the intraoperative or perioperative parameters, it was clear that open partial nephrectomy was associated with shorter operative time and shorter warm ischemia time, while robot-assisted partial nephrectomy was associated with lesser blood loss and lesser need of analgesics. The length of hospital stay, although it was lower, 2 days shorter in robotic-assisted partial nephrectomy, but it was statistically insignificant. So overall, if we see the complication, the robot-assisted partial nephrectomy scores over the open partial nephrectomy as far as the minor complications are concerned. As far as the major complications, grade 3 and grade 4 complications are concerned, both of the groups are comparable as statistically, as far as the statistics is concerned. So if we go for a mean GFR after the robot-assisted or open partial nephrectomy, so the main difference was seen in the early period of post-op day 1 and day 3, where the robot-assisted partial nephrectomy scored over open partial nephrectomy in terms of in terms of mean GFR, while this benefit was faded over the period, and it was almost similar to the when till post-op day 19. So its clinical relevance is still questionable. The potential reasons which were hypothesized that temporary kidney hypoperfusion in open partial nephrectomy because of the higher blood loss or because of the immediate post-laparatory hypotension could be the cause of this immediate fall in the GFR. And the benefits of off-clamp approach is still debatable. RCTs, they fail to demonstrate any of benefits in robot-assisted partial nephrectomy. So coming on to the limitation of this study was having a small sample size, so no conclusive confirmatory testing could have been performed. Not all patients were potential candidates for such a complex trial, and it must be treated according to the local availability of the equipment and expertise. Again, the results of secondary endpoints such as analgesia and blood loss, it was said that need to be interpreted with caution, as the trial was of exploratory in nature and confirmatory testing was not possible for these parameters. Some endpoints like loss of hospital stays are suboptimal measures of surgical quality, as they depend on local workflows and should also be interpreted with caution. Finally, it was said in this study that 2-year follow-up is still currently going on, and it will be provided very soon, and which will provide the first oncological results in terms of overall cancer-specific survival and recurrence-free survival. So the take-home message is that ROBOCOP II trial, it is the first randomized trial which provides the first randomized data for the comparison of robot-assisted partial nephrectomy with open partial nephrectomy, especially in terms of the feasibility of randomization of the patient. So it establishes the feasibility of randomization within a planned time frame, and the expected advantage, which is already known, that less blood loss and lower need of analgesia is associated with robot-assisted partial nephrectomy, was again confirmed in this study. It was seen that open partial nephrectomy was having shorter operating time and ischemia time. Again, it was already seen. Complication rates were comparable to the other RCTs. So it was concluded that each approach to partial nephrectomy, be it robot-assisted or open partial nephrectomy, has some advantage over the other, but ultimately they both are safe and effective treatment options. And it was also concluded that generalization might not be possible because other same trials like CONVERT trial and phase 3 OPERA trial, they failed to accrue the patients. Furthermore, it was also pointed out that as we are dealing with newer surgical robot systems, so in future it would be surprising to see if there is any system differences among the results. Surgeon expertise, no doubt, is the most important factor than the approach itself. And questions regarding the outcomes such as overall survival and very long-term kidney function, it remain a challenge to answer in any of the RCTs because of the ever-changing techniques and unmeasurable confounders. Thank you.